So this is the first in a series of webinars that is linked to the Palliative Sedation project, which is funded by the European Union. It's a large collaborative project across many countries, and you'll hear some of the early work that we've already completed in the project, and also think about some of the clinical implications. We're going to have time to have some questions after our three speakers. I'm really delighted that we have such eminent speakers today. Please feel free to introduce yourselves in the chat function, say which country you're from and what your role is and what your interests are in this topic. Those are going to be really useful for us, and we'll maybe be able to address them in future webinars. So I'm going to move on now to invite Jeroen Hasselaar, who's the project coordinator. He's an expert Centre for Pain and Palliative Medicine, which is at Rabon University Medical Centre in the Netherlands. So Jeroen is going to set the scene for us, tell us about the issues, and tell us particularly about this project. Over to you.
Yes, Sheila, thank you very much. Can I get the right to share screen? Yes, thank you. Just need to find, here it is. So I hope this slides can be seen in full now. So I have nothing to declare except that I am a project coordinator of the grant for the Palliative Sedation project, which is presented today, or at least the first preliminary results. My name is Jeroen Hasselaar, project coordinator. I work at the Radboud University Medical Center in Nijmegen, as has just been said. And palliative sedation is a topic that interests me for quite a decade now. I did my PhD dissertation on the topic of palliative sedation 10 years ago. I think ever since then it remained a part of the public debate. So I think it's important to give a bit of a brief introduction about what palliative sedation involves before we start our plenary discussions. This project started in 2019 and will last until 2023. And the overall objective is to enhance the proportional application of palliative sedation in Europe, in our case by research. And if you can see on this map, is the map shown? Yes. We have quite a group of international partners. For example, from England, in Lancaster, from Leuven in Belgium. We have also from Brussels the European Cancer Patient Coalition and of course the EAPC. We have the University of Navarra from Spain. We have La Maddalena from Italy, Hospice Casa Sperantai from Romania, University of Page from Hungary, and the University Clinicum Bonn from Bonn, Germany, and then our own university. And during our first years, we heard a lot of interest from other countries as well. But first, in this introductory speech, I would like to tell a bit what is palliative sedation, what are important preconditions for palliative sedation, and some cornerstones of the debate, and a very brief outline of what our project comprises. Palliative sedation, and I take the definition of the European Association for Palliative Care, is the monitored use of medications intended to induce a state of decreased or absent awareness and consciousness in order to relieve the burden of otherwise intractable suffering in a manner that is ethically acceptable to the patient, the family, and healthcare providers. This is one of many definitions, but central to most definitions is that palliative sedation aims to reduce the consciousness of the patients to relieve the burden of refractory suffering. And this is something that will come back in our talks today as well. There are more types of palliative sedation. One very known type is the deep and continuous sedation, which is mainly restricted to the last days of life, at least according to the clinical guidelines that we know. But there is also light and intermittent sedation. Light sedations are more superficial forms of sedation. Intermittent sedation can also be respite sedation, e.g. for the night. So if we talk about palliative sedation, we take a broader perspective, but we know that most of the public debate and also the clinical debate is about continuous and deep sedation. And the first precondition, if we talk about continuous and deep sedation, in particular, is the presence of refractory symptoms. These are symptoms that are actually not able to be treated anymore with conventional treatments, symptoms that cannot be relieved otherwise, symptoms that cannot be relieved in due time, because time is a factor at the end of life. And there is also the situational component. What is possible in a hospital? What is possible at home? So there are more elements that need to be taken into account. But the concept of refractory symptoms is very central as an indication for palliative sedation. Now, what kind of symptoms can we think about? What is often mentioned also in the literature is delirium. Dyspnea is often mentioned. But an interesting one is also psychological distress. Pain is often mentioned, vomiting, and there are more. And quite often we see it's a sort of accumulation of symptoms and problems that altogether result in a refractory symptom and refractory assessment of the patient. And the second precondition, also very important, is that we say that for at least for continuous deep sedation, this is very important, that death is expected soon. And this is maybe less a debate for light or intermittent sedation, because you can reverse that. But most times continuous deep sedation is not reversed, although in theory it is possible. And what we would like to emphasize here is the proportional application of sedation. And that means that the sedation is applied as much as is needed for the control of the symptoms. And this condition of death to be expected soon sometimes is mentioned as the last 2 weeks of the expected life expectancy. Sometimes a guideline says 1 week, but it's always very close to the expected end of life of the patient. And then we come to an important debate that has been there, I think, also for a decade or longer. What about life-shortening effects, or possible life-shortening effects, or potential life-shortening effects? There has been a lot of ethical debates and society debates and also clinical debate around this. And does it mean that palliative sedation can be sometimes a form of slow or hidden euthanasia? At least from the literature we know, and this is a review from 2012, that in the studies that were collected there is no empirical evidence of hastening of death around palliative sedation. And the more recent study that was published in the Lancet Oncology in 2016 of Maeda et al., they did a very big study about continuous deep sedation and survival, and also concluded that there is no effect. So in this case, one could question if these life-shortening effects are there at all. Still, there's a lot of debate around it. And to make it clear what the distinctions are, I have added a slide from Mastervet et al. About the differences between palliative sedation and euthanasia. And you can see that the intention is different. The intention of palliative sedation is to relieve intolerable suffering at the end of life. For euthanasia, it's the end of the life of the patient. Also, the procedure is different. For palliative sedation, it is to apply a sedative drug for symptom control. And the expected outcome for palliative sedation is the alleviation of distress, which is also different and not aimed at immediate death. So I think it's important to keep this in mind. There are still discussion points, and some of them will be addressed later in this seminar. For example, palliative sedation and decision making. You need to have respect for the autonomy, for the wishes of the patient. But this implies also that there needs to be a timely discussion. And sometimes this timely discussion is not so much possible if refractory symptoms and intolerable suffering are there. So how do you go with that? And then there's also the role of the family in the decision making. Family can be very distressed. How you can deal with that as a caregiver, and how you can involve the family's perspectives in the decision making when it's appropriate. Another discussion point is the indication, what already was mentioned before, refractory symptoms assessed by a clinical team, but also the unbearable suffering. That is also where the voice of the patient comes in. So some type of shared decision making is important where possible. And it's also about this proximity to death. Sometimes it's difficult to estimate as a caregiver how close the patient is to death. And then you need to make a balanced decision by preference within a clinical team and not as a standalone caregiver. And there are questions around palliative sedation and existential suffering. What is the place of existential suffering as an indication for palliative sedation? The literature is quite hesitant about that. But in practice, we see that existential questions often exist for patients. And we need to deal with that. So this is also a question for debate. And the last thing I want to point to is palliative sedation as proportional to symptom relief. And if it's really applied in a proportional way and administered in a proportional way, it seems, according to the literature, that life-shortening effects are unlikely to happen, and that we should not qualify palliative sedation as hidden or slow euthanasia. But on the same hand, we also know that debate and ethical debate is still there. Back to our project. In our project, we would like to study more elements around palliative sedation. We have started with a literature review, work package 1, which is already done, and Maria will show some highlights of that. We have started now an observational study, which has been delayed due to the COVID crisis, but it's opened now, and we're looking forward to the results. We will have a caregiver interview study, a moral case deliberation, but we look forward also to work package number 6, which will involve a revision of the current guideline and framework of the EAPC in Europe. And Delphi panels are currently being performed. We will have online education, we will have cost consequence, and we will update the public by dissemination. To conclude, palliative sedation increasingly is accepted in Europe based on practice guidelines, aiming at the proportional use of palliative sedation. However, practices vary, and ethical and clinical reflection remains very important. Very much, and enjoy the webinar.
Thank you very much, Jeroen. So I'm going to ask you now to stop sharing your presentation. Thank you. So we move now to our second presentation. So Maria Arantes-Amendi from the Atlantis Research Group at the University of Navarra in Spain. She and her team have been extremely active in searching and conducting high-quality literature reviews, some of which are published. And we invite you, Maria, to tell us more about those literature reviews now, please.
Thank you very much for the presentation, Sheila. Welcome, everybody, to this webinar. We hope that you enjoy it. I'm trying to share it in bigger screen, but I don't know if you see it in bigger screen. Do you see it right now? Okay. So welcome everybody. As Sheila said, my name is Maria Arantes-Amendi, and I'm working at the University of Navarra at the Institute of Culture and Society in the Atlantis Research Group. We have been in charge of conducting the first work package of the European project that Jeroen has presented. Today we want to share some of the progresses made in the work package 1. So we are going to talk about the clinical aspects of palliative sedation. And the outline is going to be talking about the assessment of refractory symptoms, the assessment of palliative sedation effect, considering mainly the comfort measurement tools and the level of sedation measurement tools. We will focus on the assessment considering the timing and the health professionals involved in it, and also on the incidences. We are going to tackle these aspects based on the literature review that we conducted with the help of all the consortium members. It's published now, but here is a brief summary of the key aspects trying to answer to these outline elements. So briefly, I want to mention just the characteristics of the literature review we conducted. The aim was to understand how the potential effects and possible adverse events of palliative sedation in palliative care were assessed. We conducted literature review, specifically an integrative type of review, searching on Cochrane, Embase, Medline, PubMed, and CINAHL. We use terms that were quite global, using, for example, words like sedation to try to capture different types of sedations. And we combined with palliative care, terminal care, and assessment. And the focus was mainly on assessment. And within the inclusion criteria, we decided that we will focus on scientific articles that focus on assessment or specify how they conducted the assessment. Articles that were conducted in any type of setting within palliative care and end-of-life care, participants over 18 years old, and patients who had advanced incurable disease. So conducting the search strategy, we achieved identified 26 studies, and these were analyzed in full. As you can see here in this slide, these 26 studies represent the studies from many countries. In total, 14 different countries have been publishing about palliative sedation. Most of the studies we have to acknowledge that are being conducted with patients who had cancer, but there were some studies, specifically 8, that also included patients with non-malignant advanced illness. Majority of the studies were conducted in palliative care services. It could be different type within palliative service. It could be hospice, palliative support services within hospitals, or even community services. And there were just a couple of studies conducted in oncology wards or nursing homes. And as you can see, there are a lot of studies that are being conducted prospectively. 14 were identified in which data collection was conducted prospectively, but only one was an international study involving 3 different countries. The others were regional or national ones. One thing that we took into account, and I think it's important, is to explain which was the context in which the studies were conducted and the palliative sedation was being administered. All the studies specify that they were using palliative sedation in the context of end of life, which makes sense considering also the search strategy, but there were some peculiarities or nuances there. Most of them, as Jeroen said earlier in the presentation, were at the end of life, but within there were different. Some specified that it was the last phase of terminal illness, 2 weeks, sometimes last hours or few days, and there was just a couple of studies that talk of 6-month expectancy of life, and there were situations in which patients were being administered intermittent sedation. All the studies refer that condition to administer palliative sedation had to be a refractory symptom, and a lot of them provide the definition that is presented in the slide that says that it's an intolerable symptom, severely burdensome, that cannot be controlled within usual palliative care resources. What we are going to see now is what type of refractory symptom were mentioned in the literature, how was the assessment conducted. In the literature, the symptoms, refractory symptoms that are mentioned on the studies are similar to the ones that Jeroen presented. It's about delirium, dyspnea, pain, vomiting, this type of situation. But it's worthy to highlight that there were many tools mentioned being used to assess the refractory symptom. In total, there were 15 studies named, and that's reported in the paper that we have published. But here I wanted to highlight some that are commonly used in palliative care context and have been validated, which are the ESAs that helps to assess different symptoms within the same instrument. Then the other one that was highlighted through the articles was the Memorial Delirium Assessment Scale that is also validated to palliative care. There was also one other instrument validated in palliative care, that is the Critical Care Pain Observation Tool that is being used also to do the assessment of pain. There was also occasionally a reference to profound psychological or existential distress as one of the conditions to consider palliative sedation, but it was not specified on the articles how this assessment was conducted. And in the cases that profound psychological or existential distress appeared, often was also together with other refractory symptoms like pain or delirium in the patient. So it was one patient having several symptoms. Regarding the effects of palliative sedation, we identify in the literature that it's been assessed the comfort of the patient. That's something different from previous reviews on tools being used for assessment, like the Brinckemper study didn't identify comfort assessment tools being used. And here we can see that two are being used: the discomfort scale dementia of Alzheimer's type, the patient comfort score. So both of them are a possibility to assess comfort on patients. That was one of the ways to assess the effect of palliative sedation. But we also have to mention that there were several assessment tools used to assess the level of sedation. Even if that wasn't the main purpose of the sedation, this was assessed. Most used tools are the Richmond Agitation Scale and the Ramsay Sedation Scale. And there are some specifically validated for palliative care sedation assessment tools, which you can see here in the slide: the Richmond Agitation Scale palliative version, the Guideline for Palliative Sedation for Royal Dutch Medical Association, and the Conscious Scale for Palliative Care, and the Agitation Distress Scale. So we can see that there has been an increase on the tools available and being used in the clinical context. Regarding the timing of the assessment, we have identified that when reporting the studies, nurses are mainly conducting the assessment, followed by physicians, researchers, and sometimes it's mentioned in general that palliative care professionals are the ones who are conducting the assessment. Regarding the timing of the assessment, there is a quite high variety. It's mentioned within the measurements during the sedation that the minimum measure done every day can range from hourly until the first 4 hours, then between 2 to 6 measures per day, then even sometimes every 20 minutes until it's assessed that adequate level of sedation has been achieved to control the refractory symptom that made professionals to consider palliative sedation, and then doing the assessment 3 times a day. So as you can see, there is some variety on the timing of the assessment. One of the objectives also was to see if there were any potential adverse effects on the studies being reported. We have identified that The most discussed aspect is about the possibility of hastening death. And the review shows that different studies show that there is not evidence to have this concern about hastening death. In fact, there are some studies that suggest that it's not the case and that even patients sometimes can live a bit longer. There is also one study that mentions that some patients, a small number of them, have some decreased oxygen saturation. They argue that there were patients who were very much close to the end of their life, on the dying process, so that this decrease on oxygen saturation might be on the process of dying itself and not related with the palliative sedation. On the incidences also, we identified one article that talked about patients regaining consciousness during the process of sedation. That was something that concerned professionals and also families. Some families were also concerned about the sedation process. And in one study, there was also some concern on the health professionals. There was a study that sedation was conducted in primary care context, so they were doing home care attention, and they didn't feel so comfortable on providing palliative sedation, so that created some challenges for them. So these were like the incidences reported in the literature, considering them in a broad approach, because the studies don't report any specific adverse event. So to conclude, we can say that it's clear based on the literature that the aim of palliative sedation is the relief from refractory symptoms, that there are available validated tools to assess the effect of palliative sedation in palliative care contexts, that there are tools validated to assess the comfort and the symptom relief, which are the focus of the palliative sedation effect. There was no instrument mentioned on the studies to assess profound psychological or existential distress in the studies reviewed. It was clear also from the review that a holistic clinical assessment is needed, and that has to be complementary to the tools used, as there is need to know about how to proceed adequately on providing an assessment in palliative sedation. Future research should include a systematic assessment and documentation of potential adverse events, as is something that hasn't been so systematically explored. Here I have included some references, thinking that they might be useful. Thank you very much for your attention.
Thank you very much, Maria, for an excellent presentation. It's wonderful to hear about all the careful reviewing and the evidence you're now able to provide. Now, of course, this is a clinical issue, and it's really good that our next speaker can address that topic. So I invite Chris Visvers, who is from the Department of Anesthesiology, Pain and Palliative Medicine at Radboud University Medical Center in the Netherlands. Chris has extensive clinical experience, and we really look forward to hearing his views on this topic. Thank you.
Thank you, Sheila, as a chairwoman, and thank you, team members, and thanking all the audience with very famous people in it on these clinical case presentations. And I'm very happy that the EAPC is doing a webinar on reflections on palliative sedation. And I would even say one step further, all people working clinical practice, medical or nurse or psychologist, we all need to have regular contact on this topic because we have a lot of cases every day who presents with difficult questions in the whole story of palliative sedation. So thank you for your attention on this. Just my disclosures, I have a lot of motivators why to ask me to give a lecture, and I have no paid honor industry paid relations sees no area for lecturing. So I hope that that will give you a good feeling. But important as a medical professional is that we should understand suffering. And suffering is a state of distress by an actual or perceived threat to a person's integrity or a sense of self, a threat to personal autonomy, and a state of anguish as a person experiences pain, injury, of loss. And we all live the situation with patients who had a very bad news talk with their oncologist or the lung or the cardiac specialist, and that these people are suffering not only from their end of life, but also what will happen with their family. So understanding suffering is a core skill of all palliative care professionals. And therefore, I think we need guides, but they are very few, and we should work very hard. And it was very nicely shown by Maria that we need to have guides not only for physical, but also for psychological and spiritual care programs to understand refractory pain, refractory suffering from symptoms, whatever. So really important to look at. One step further is that the clinician experience of refractory suffering is huge, I think. For the Netherlands, for example, we have each year 40,000 sedations a year, between 35 and 40,000 palliative sedations a year, which is a huge amount. And we can question if all these sedations are properly done. And that is the reason why the literature about all the ethical part of palliative sedation is much bigger than the literature about understanding how to perform a good palliative sedation. And the clinical presentation is important to do that. So we need, in this challenging area, we need guides who are courageous, who are prepared to undertake a pilgrimage alongside the suffering person. And we should be aware and in the neighborhood of a patient and his family to understand what happens during this moment in a person's life. And that is really important. We should make bearable in the presence of the concerned others. We had a lot of debates. What is a good palliative sedation? And of course, are we thinking about instrumentalization and monitoring programs? But for all the clinicians, we know that it's very easy to see when you have a quiet situation in a quiet room with a quiet family on a quiet location that the patient wished, and that you see no stress and no movements which are involuntary and no emotional explosions. I think you are doing well your medical practice. And finally, I want still to say that a lot of people are expecting for end-of-life help, but it's not always necessary. We do have still a lot of people dying on a natural way and on a very peaceful way. So I think that is important to mention before we go to case presentations. The important question is how much palliative sedation do we need? And I think that Jeroen was really giving a good introduction that we do have deep palliative sedation for cases which will end the life at the end, but we have also proportional palliative sedation, and that's more difficult because we have to monitor the patient. We have to ask what is the aim of the sedation and what are your expectations during the day. And that's not only true for young or older patients, but it's also true for different religious populations which have their own requirements depending on their religion and giving place to a palliative sedation. And we can have a debate on that later on. We have very nice frameworks, the EAPC framework of palliative sedation, which will be reviewed, and I'm very happy with that. For my country, we do have a Dutch guideline, which is guiding for my medical practice. I have to apply it unless I have severe reasons to not applicate the palliative sedation guidelines. So that is an important one. And just to present you very simply from the clinical way, what are the 3 steps of palliative sedation for all healthcare professionals in the Netherlands? We have a first step of midazolam, 10 milligram bolus subcutaneously, which can be followed by a pump subcutaneously or IV, and that depends on what you observe in the patient. Therefore, we made obligatory that any professional, and for sure the medical doctor, the GP, should be present in the first 2 to 3 hours until the moment you get a quiet sedation and a good sedated patient with a happy family. In a step 2, you can have levomepramazine, 25 milligram of a bolus, and followed also, if necessary, by a continuous infusion. And it's always a lot of discussion in clinical cases. Should you go on with midazolam and add levomepramazine, or should you do both separately? There are no good clinical trials on that, and I really invite the audience to think about doing prospective studies on this topic. We have a final proposal. This is step 3 level, and that's a more really anesthesiological approach of sedating with propofol, which is very hard in the home situation, which is very costly in the home situation, but which can help in very refractory sedations at home or in the hospital. And these are the 3 steps we should consider in teaching our people and our healthcare professionals how to perform a palliative sedation. And this is quite in relation with other countries in Europe, as we observe. So the first case I want to present you is a lady of 60 years old with metastatic lung cancer and very progressive deterioration while she's holding the bed. And this lady has a very progressive dyspnea, very short of breath, weighing only 40 kg, yeah, and she had a spontaneous hip fracture due to metastasis, and that's the reason why she was referred to the hospital, in the hope that still operation was possible, but that was not possible. And one step further, it was a smart lady, in my opinion, when I saw her. She was refusing even the operation because of uncertain outcome, and that you understand, because of the metastasis. So we started first with the subcutaneous morphine in progressive doses, yeah, but it was very hard to move and to mobilize her in the bed and to support her in her care program because of the pain. So there can be several pathways now that I can question to you in a voting program, but we are not voting yet. So we hope to make that for the future with the EAPC, because some people are performing now in the last months, for example, a pain block. Yeah, you can block the hip neuroanatomy so that pain is immediately away and that we can observe how to do it then. But that was not done at that period when I saw this lady. So we have refractory symptom of pain and progressive dyspnea. The patient and the family, with whom I had really extensive discussions, because they were not prepared at that age to think about dying of a disease. Yeah, so that is really important, that the proactive identification of a patient was not really explored at the moment that we saw her on the emergency department. So it's important that you agree with patient, yeah, in a very good consent manner, and with the family, and explain also that you will treat the quality of life, but not shorten life. And a lot of people do like that message. So that's an important thing to think of. Secondly, due to the sedation, you have to think about quality of life also, for example, by placing a bladder catheter, because people cannot voluntarily vote anymore. So that can be a reason for agitation during the sedation. So you have to avoid that. And finally, when you have time, please introduce a goodbye ritual, which we do with the spiritual caregiver, and all the people, the patient in this case, the lady, and her family was very happy to do so. So we started the proportional sedation with midazolam and levomepramazine. Within the 8 hours, we had a stable situation and a very peaceful situation. And from that moment, people were in the room, just talking to her, just telling stories and saying, you can go if you want, but stay with us as long as you are there. And I think that fits perfectly in our mission of palliative care. So the time of dying is no longer important at this moment, except when cases of palliative sedation will prolong dramatically. And I invite you for the discussion to question these. A second case I prepared for you is a more difficult case, and a more case which gives a lot of discussions, often in the clinical practice. It's a 77-year-old male patient. Since 6 months was he in the somatic disease department of an elderly care home facility. He was very fragile. It was very hard to walk. His wife died already 10 years ago. He has 7 children, but they are very busy, and they were living at the other side of the country at more than 150 kilometers from the patient. And he had a COPD with the goal 3 state, which is a huge state of shortness of breath, because you cannot walk the stairs, you cannot do anything anymore, and you have a lot of exacerbations, like he was doing in the last year. He had more than 4 severe pneumonias. So that is a case where we should discuss very proactively how this guy is thinking about his end of life. For sure, when you see where we were observing the Karnofsky scale, we are doing that in every patient. When the Karnofsky scale goes below 50, please start your discussion about end of life care. He was sitting in a wheelchair, needs a lot of help in his self-clotting, and his current treatment were, of course, the presence of his children, but also nebulization with bronchodilatators, corticosteroids, sitting up in the bed, and all these other parts which were very important. But we saw also that there was progressive desorientation, memory of loss, and happily we concluded not to reanimate anymore when it was necessary. So the dyspnea became really very progressive. At the moment I was on call, and I saw a very dyspneic patient with a temperature of 39 degrees, not eating, not drinking, not moving in bed. And the examination of the mouth, the heart, the abdomen, the legs were quite normal, but the lung auscultation confirmed a decreased ventilation at the left lower field. And with the temperature, you know that you have a severe COPD with goal 3, with a severe pneumonia in a patient with strong cognitive frailty. And then is the question, what should you do? Should you start with antibiotics? Should you discuss with the children, what is your pathway, your scenario for these patients? So we had medical discussions, and the family was not supporting the idea of antibiotics. And when they were hearing the prognosis of the disease, even with the antibiotics, there was a wish of the patient to go for no futile treatments. And that's an important point. The prediction of futile treatments is very difficult, and again, an important point for discussions. So our treatment plan was, first of all, to continue the nebulization, start subcutaneous morphine because that helps the feeling of dyspnea, stop oral intake to limit overfilling of the patient, and in the next days he had a strong deterioration, unless the morphine subcutaneously. He had strong signs of delirium, so we started with haloperidol 2 times 2 milligrams subcutaneously, and he had progressive cognitive deterioration and motoric restlessness. This is a patient which is in the ward of hospital, very hard to deal with. It's also equally true for a long-term care facility. So the discussion was about the refractory symptoms in this case with dyspnea and delirium. We started with the palliative sedation, very low doses, 2.5 milligrams because of his frailty, and we had a bolus of 10 milligrams later on, and he was again well sedated and died 6 hours later. So we didn't make the respiration impossible, but we gave comfort to this patient. And I think the team, the medical team, but also the family was quite happy with the way that this end-of-life care was installed. For the next webinars, we have a lot of discussions possible, but that's for our chairwomen. We have patients with ALS, we have patients with Parkinson's disease, general frailty, dementia, existential suffering, but I think for now, the floor should be open for questioning. Thank you, Sheila.
Thank you very much. You've raised so many interesting issues, and thank you for sharing some of your clinical case experiences. So we now have around about 15 minutes left of this webinar. And thank you to all the attendees. When you registered, you were invited to send questions, and many of you did. And we've looked at those questions carefully. And I'm going to put some of those questions to our expert panel. And I'm going to start with inviting Jeroen first to think about and tell us a little bit more about his views on palliative sedation for people suffering from existential distress. Jeroen, what's your views on this?
Thank you very much, Sheila. I already mentioned it as a question mark in my presentation. because there's a lot of discussion going on around this also in the literature. I must say that the majority of the literature would say to be very hesitant if existential suffering is the single or most predominant symptom. Because in case of existential suffering, it's more difficult to estimate if the patient is close to death, for example. And it's also not always clear if a medical treatment is the best way to solve existential suffering. So at some point, maybe you pass these kind of questions, but that would be a reason for me to be hesitant if existential suffering is the predominant reason. But also we saw in research that quite often existential suffering or questions are posed by patients in the last phase of life. So also we cannot deny that these kind of questions are there. And as Chris said in his presentation, it should be well assessed also by the clinical team. So I think it's a bit a balanced answer. I think existential suffering, when it is there, it needs to be taken seriously. But in itself, one should be hesitant to make this a reason to start palliative sedation.
Thank you, Jeroen. So much to think about and to further research during our project. So another question that we had, and I'm going to address this one to Maria. In your review, you highlighted that there were many different terms. Can you advise us which is the preferred term or which ones you would recommend that we use in this area?
Thank you, Sheila. Thank you for the question. I think there is also an important discussion, I think, about the terminology. When we did the research, reviewed the literature, we avoid using some mesh term that already had a very specific way of defining sedation, and that's why we use the term sedation on this when running the searches. But we have identified more than 8 different terms to talk about this idea of palliative sedation. And I think what was more useful was to really have a clear definition, or at least an explanation of what clinicians were doing when they were talking about palliative sedation. So that helped really to understand what was being applied. As Jeroen said also in his presentation, there are different levels, and I think that also creates some confusion sometimes also when naming the sedation. So I would say that in general it would be good to use just the word palliative sedation and then explain more in detail what we are talking about, so that everybody can really understand what's under this term, instead of using more if it's deep, continuous, light, because then it creates sometimes more confusion because different wording adds different peculiarities.
So the message I've got from you, Maria, is to keep it simple, and then hopefully that will be clear to us in our clinical teams, but also helping us communicate clearly to patients and families. So thank you. So another question, which I think comes from one of our clinical attendees, is directed to you, Chris. I think it would be really helpful if you could perhaps summarize what are the indications for palliative sedation, and then share your experience about how suitable it is in different settings. For example, in the home, in the inpatient hospice, or in intensive care.
Yeah, this is a wonderful question of the person who is asking this question, because we are all looking, when should you apply palliative sedation? And Jeroen stated it very clearly. For intermittent or appropriate sedation and patients still want to wake up, I think it's clear that you can do that in very easy pathways. However, when you choose for deep sedation, the advice is, and a lot of guidelines state that also, that you should have patients who will die naturally within 2 or 1 week. Yeah, because when patients will not die, all of us know that we can sedate for months on the ICU. We all saw that during the Corona pandemic now, that people were on the ICU for 60 days, for 80 days, for 90 days, and were surviving. We saw all these cases. So we can sedate on a very high quality level with nutrition and with fluids and with the family around and whatever. But in the case of a palliative pathway and terminal pathway, I should say, please go for end-of-life sedation. And that's not the term as the term that Maria discussed it. It's not only for somatic reasons. I think that's the most obvious one. That was the first tryout in the past years for oncological patients. But I think we really should consider other reasons also, like refractory depression, anxiety, demoralization, or existential distress. And just this weekend, I was on call. I had a lady of 30 years with an undiagnosed cancer, but full of metastases. I really can understand that she is an existential suffering with a child of 1 year, a second child of 5 years, a young husband, and with a situation that she was healthy 2 months ago. She was not prepared to die within this weekend. So an existential combined with very severe somatic refractory symptoms can be a major reason to look to a good care program. And the palliative sedation would be a part of that. That's really important.
Thank you. Thank you for sharing that advice.
The second part is really dependent on the country, and I think Jeroen can also say something on that, because we observe that there are countries where the majority of patients are sedated at home, like the Netherlands. It's less in Belgium. It's even less in Italy, I think. It's less in Germany. So the pathway for sedation, that can be a strong discussion, and also for another reason than only practical reasons, because for me, as an anesthesiologist trained in pain medicine, sometimes it's hard to believe that a symptom is refractory if you didn't have a specialized consultation of a palliative care or pain team. And that can be a very tough discussion, but I want to open that debate, because I think that a GP is wonderful in a lot of dimensions, but we have more and more high technological help strategies for these symptoms, and they should be involved in the medical practice, also for palliative care.
Okay, so that's an important message about consulting with colleagues who have expertise that may well offer some interventions that perhaps you as a clinician have not considered. So thank you. So I'm going to return now to Jeroen, because we've got a very interesting question from somebody who would like your views on the applicability of palliative sedation to different religious groups. I think you hinted at that in your opening talk. Would you like to tell us a little bit more, please?
Yeah, well, it's an interesting question. I think actually Chris mentioned it, but I think that when I wrote this proposal 2 years ago, there was a bit of literature about how palliative sedation is perceived, for example, in Western European countries versus Southern European countries. And then it was related to the background where they come from historically, like a Protestant background or a Catholic background, and that it could also influence the way how you look at end-of-life care. For example, one thing that was mentioned in that article, if you are more based on an autonomy perspective, or where you want to control more at the end of life, or if you are more based in a sort of perspective where you want to give it out of your hands and just let it happen, or being dependent on others is a problem or not a problem. So it was quite interesting. And I know also, but I don't want to go in full detail there, that there are some opinion articles about how sedation is perceived in specific religions. But I found this one, what I just mentioned, interesting, and it made me also realize the cultural aspects that are there at the end of life, and that also need to be respected.
Thank you. I'm working with colleagues in the Middle East, and I'm learning a lot about an Islamic perspective on palliative sedation and other end-of-life care options. And I think that is a wider debate that we'll have in our global communities. So I'm going to turn to the next question to Maria. Maria, in your reviews of the literature, have there been any evidence on any contraindications for palliative sedation?
And no, not really. I mean, on all the articles that we had reviewed, there was not contraindication. There was some concern about the idea of hastening death, but the evidence is not supporting this concern, and there was not any other contraindication for palliative sedation. I think Chris wants to add something.
Yes, because I think the most important contraindication, having no refractory symptom. So I think in the beginning, the monitoring of the sedation is really important to understand what's happening, and you should explore the cause why you have to sedate or why you have a refractory symptom. So that's a really important point, I think.
Yeah, but I agree with that. I mean, it has to be a refractory symptom, and I think the assessment has to be done by people who know how to assess and with plenty of experience and using the adequate tools. Yeah, completely.
Okay. So we have some consensus amongst our panel members of the importance of good quality assessment from people who have the expertise to do that kind of assessment, and to consider all the possible options that are available and should be offered to the patient and family. So, Chris, there's a question, I think, once again from a clinician who would like some advice on what you consider to be the best medicines, drugs, and what kinds of dosages. You did highlight some of that in your presentations, and whether or not it should be we should be combining medications in the process of palliative sedation.
Yeah, very good question, because I think that your national society should be guiding you together with the EAPC that what is the best guideline for your country. We did that process in the Netherlands, and so I showed you what we concluded in the Netherlands, always to start with midazolam, then the levothyroxine, and finally in, let's say, a Plan B program, the propofol. So the dosages, you can easily find these on the internet. We have made even for all GPs and all the healthcare professionals in the Netherlands an app on your phone so that you can easily check what you should give to people. So that's really very handsome. And please, if it's difficult in your country, because you're coming from all over the world, you can connect to us by our email, for example, also to learn how we manage that question. There is one question also in the chat, which is a good one, because I only named 3 of these drugs, but we do have another which are very good candidates. There is somebody who is asking the question on dexmedetomidine, which is very old anesthetic in a way, but there is no prospective study. And my opinion is, as long as we have no effective prospective studies, we can not make a conclusion to put it in the guideline. Can it be helpful in individual cases? Yes, because that's true for other medications, but our agreement nationally and internationally is that we follow the guidelines. I hope that this person can find these guidelines, and if not, we can make some messages on the EAPC website.
Thank you. So there's some sources of support and advice for people who need it. So please use them or contact some of our panel members. I'm going to draw this webinar to a close now. Thank you so much to Jeroen, to Maria and Chris for sharing your expertise and your knowledge so freely. It's been a pleasure to hear what your views are and your research. Thank you to everybody who's participated. It's been incredible. I've seen messages coming from all over the world. I hope that means that you're not feeling sleep deprived, because I'm sure for some of you, it'll be the middle of the night. Please watch this space. We are going to be doing further webinars on this topic, and I haven't got the dates at the moment, but they will be coming up. So we'll inform you all, we'll put information out on Twitter. And of course, if you want to share this recording with some of your colleagues to help improve the skills and knowledge about palliative sedation, you're very welcome to. So a big thank you to the panelists, but also to Kathy Payne and her team from the EAPC for coordinating and organising it. So goodbye to everybody, whether it's a good afternoon, a good evening, or a good morning, wherever you are in the world. Thank you. Bye now.